Welcome friends, now we are going to discuss tumors of small bowel. Okay, so this topic is going to discuss on tumors of small bowel. So I would like to tell some important points related to small bowel tumors. Okay, related to small bowel tumors. If you see, your GIT is made up of esophagus, stomach, small bowel, and colon and rectum. This is a total GIT. In this GIT, if you see, which is the largest part of GIT? The largest part of GIT is small bowel. Small bowel is the largest part. But the interesting point is, the percentage of GIT tumor in small bowel is only 2%. So please remember, the percentage of tumor in small bowel is only 2%. Why is it so? Why the small bowel tumor is only 2%? The point here is, you must understand, small bowel has rapid transit. So the food particles are moving very fast in the small bowel. So there is a rapid transit of food particles, number one reason. And number two reason is, there is not only rapid transit, there are full of Peyer's patches. So because of Peyer's patches, if there is any tumor, that tumor will be engulfed by this Peyer's patches. Okay, and there is a rapid epithelial turnover. Epithelial turnover is very fast. Though this is not an MCQ, this is one of the practical point. Epithelial turnover is very high in small bowel. Therefore, even if small dysplasia happens, that epithelium falls and the new epithelium grows. So for every 2 to 3 weeks, there is new epithelium growing in the small bowel. So these are some of the reasons why the tumor in small bowel is rare. So small bowel adenocarcinoma is very rare compared with other places. It is only 2% of the GIT cancers. Okay, so please remember, I am going to tell you the tumors of small bowel compared with tumors of liver in comparison. I am going to tell. Why I am comparing liver here? Because they are mostly interrelated. They look like same. So what is the most common tumor overall? Most common overall tumor of small bowel and liver? It is no doubt, it is METS. METS is the most common tumor of small bowel overall. And liver, again METS. So for small bowel and liver, the most common tumor is METS. And most common primary to produce small bowel METS, small bowel zero cell METS is from GIT. From the GIT only, the primary comes to the small bowel. And most common primary to the liver is from colorectal cancers. Colorectal cancers produce liver METS most commonly. So please remember, this is directly an MCQ. Most common primary for liver secondary is colorectal METS. Please don't forget that point. Then extra GIT or outside GIT, most common primary for small bowel METS. It's an interesting PG Chandigarh question that is from malignant melanoma. Extra GIT, extra abdominal or extra GIT is from malignant melanoma in small bowel. Malignant melanoma produces small bowel METS. That is extra GIT. When you come to liver, extra GIT or outside GIT, the primary is commonly from, yes, you will know that. What is it? Cancer breast. That is from cancer breast. So please don't forget that is from cancer breast. So tumors of small bowel and tumors of liver, I am comparing. So most common from primary is GIT for small bowel, colorectal for liver. And extra GIT is from malignant melanoma and cancer breast for liver. Now coming to the most common benign tumor of small bowel. Most common benign tumor of small bowel is adenoma. Second is leiomyoma. So there is also another question, which is the most common symptomatic benign tumor. Most common symptomatic benign tumor. Most common symptomatic benign tumor is leiomyoma. Overall, it is adenoma. Autopsy series, it is adenoma. In autopsy series, it is adenoma. And they are mostly asymptomatic. If you ask you symptomatic, the most common is leiomyoma. And similarly, coming to liver, most common benign tumor of liver is hemangioma. Okay, hemangioma. And most common primary malignant tumor of small bowel. Most common primary malignant tumor of small bowel is, please don't forget, it is adenocarcinoma now. The answer is adenocancer. Okay, the most common primary malignant tumor of small bowel is adenocancer, followed by carcinoid. Carcinoid is now pushed to second place in the small bowel. Previously, adenocancer was second, carcinoid was first. Now, adenocancer has become the first. And adenocarcinoma is most common in duodenum. So, duodenum is also a part of small bowel. So, the most common site of adenocancer in small bowel is duodenum. And what is the primary malignant tumor of liver? It is very well known answer. Primary malignant tumor is hepatocellular carcinoma. So please don't forget this table. It's an interesting table. So I'm comparing small bowel tumors with liver tumors. This is one method of preparation. When you are preparing a topic, we should always compare with a similar other topic. So when you start comparing two topics, both the topics will be there in your brain. Very strong. Okay, always try to compare two important topics. So the most common benign tumor of small intestine is adenoma, hemangioma in liver. Adenocarcinoma is the most common primary malignant tumor of small intestine, whereas HCC in liver. And coming to appendix. In appendix, what is the most common tumor? We are going to discuss this in appendix chapter. Just for completion, I'm telling the most common tumor in appendix is carcinoid tumor. Please don't forget, carcinoid tumor is the most common tumor of appendix. Okay, so now let us discuss a few points from adenocarcinoma of small bowel. Adenocarcinoma of small bowel. Adenocarcinoma of small bowel is only 2% incidence. Only 2% incidence. And it is associated with the following syndromes like familial adenomatous polyposis can develop duodenal adenocarcinomas. So the predisposing factors are associated with FAP and associated with Crohn's disease. Crohn's disease is one of the important predisposing factor for tumor. So FAP and Crohn's disease are associated with adenocarcinomas. Okay, and the most common site of adenocarcinoma is in duodenum. It is in second part near the ampulla. So it is in the second part. The most common site of adenocarcinoma is near duodenum in the second part. In Crohn's disease, cancer is common in terminal ileum. Please don't forget, this is a different point. In Crohn's disease, cancer is common in terminal ileum. And this type of adenocarcinomas are common in old males above the age of 70 years. Most common age group is above 70 years. Old males is common. And the point here you should remember is when they come to you itself, they have metastasis. So when presenting itself, they come to you with a metastasis. Presentation time itself, small bowel mets are present to distant site. And the commonest clinical feature is pain abdomen. So they can present as pain abdomen. Okay, that is one of the commonest clinical feature. It can present with melena. It can present with intestinal obstruction. Like that, many other clinical features are there. Once you diagnose small bowel tumors, the usual investigation of choice to diagnose small bowel tumor is CECT abdomen. It is usually diagnosed in CT abdomen, and please remember there will be CEA elevated. Tumor marker elevated is CEA. And if the tumor is operable, treatment is resection of the tumor. Resection of the tumor. For example, if there is a tumor in this part of small bowel, we should give both sides how many centimeter clearance? 10 centimeter clearance is given on both sides, and we have to resect including the mesentery. Adjacent mesentery is also included. Adjacent mesentery is also included in this resection. So 10 centimeter clearance with adjacent mesentery, which will contain the nodes, is also removed. And after resection, there is FOLFOX chemotherapy given for these patients. FOLFOX chemotherapy is given for them. So the chemotherapy for the post-operative small bowel tumors is folinic acid. That is nothing but folinic acid, which is also known as leucovorin. And F stands for 5-FU. OX stands for oxaliplatin. So this is FOLFOX therapy. Folinic acid, 5-fluorouracil, and oxaliplatin is the chemotherapy given. FOLFOX therapy. So please don't forget, adenocarcinoma of small bowel is the least common site of cancer in the GIT. It's the least common site of cancer in the GIT. And the purpose of this chapter is to discuss now the important tumor known as neuroendocrine tumors. Neuroendocrine tumors, also known as NET. So neuroendocrine tumors are also known as amine precursor uptake deuptake tumors. Apudomas are also known as apudomas. Neuroendocrine tumors are also known as amine precursor uptake deuptake tumors. Okay. And please remember, these type of neuroendocrine tumors have special function. The tumors will produce certain substances. They will produce certain substances. And those substances will have some function. That is why they are known as functional tumors. That substances produces some function. And all these guys will have a receptor like this. What is this receptor? All neuroendocrine tumor will have somatostatin receptor. All neuroendocrine tumors will have somatostatin receptor. So now tell me where all neuroendocrine tumors are seen. A neuroendocrine tumor in lung is known as what? It is known as small cell cancer. A neuroendocrine tumor in adrenal is known as pheochromocytoma. A neuroendocrine tumor in brain is known as medulloblastoma. A neuroendocrine tumor in CNS is known as neuroblastoma. A neuroendocrine tumor in thyroid is known as, what is it? Repeat MCQ, medullary cancer thyroid. It is medullary cancer thyroid. And in pancreas is known as, what are the neuroendocrine tumors of pancreas? They are insulinoma, gastrinoma, somatostatinoma, VIPoma. There are so many lists we will be discussing in pancreas. So like that, every organ has some neuroendocrine tumor. And the neuroendocrine tumor of intestine is known as what? Intestine, or otherwise of gut. Neuroendocrine tumor of gut is known as carcinoid tumor. So neuroendocrine tumor of GIT is known as carcinoid tumor. So please don't forget, neuroendocrine tumor can happen in lungs known as small cell cancer, adrenal known as pheochromocytoma, brain known as medulloblastoma, CNS known as neuroblastoma, thyroid known as medullary cancer, and pancreas known as insulinoma, gastrinoma, and VIPoma. Can you tell me why I have written insulinoma alone in green color? Why should I write insulinoma alone in green color? Other things I have written in red color. The reason is all the tumors have somatostatin receptor except insulinoma. Insulinoma has no somatostatin receptor. Please don't forget this point. The only neuroendocrine tumor which will not have somatostatin receptor is insulinoma. All other neuroendocrine tumors will have somatostatin receptor. Okay, all other neuroendocrine tumors will have somatostatin receptor. And we are going to discuss one of the most high yielding topics for PGME exam, that is carcinoid tumor. So carcinoid tumor is a tumor of gut. That is, what is that? We have foregut, we have midgut, we have hindgut. So embryologically these are the foreguts: foregut, midgut, hindgut. Foregut includes bronchus and esophagus. So tumor arising in bronchus and esophagus are known as foregut tumors. So though it is not exactly midgut, book classifies stomach tumor as midgut, gastric tumor as midgut, small intestine tumor as midgut, colon tumors, right colon tumors as midgut, and appendix tumors as midgut. So what are all midgut tumors? A carcinoid in the stomach, a carcinoid in the small bowel, a carcinoid in the right colon, a carcinoid in the appendix are known as midgut carcinoids. And hindgut carcinoids include left side colon and rectum. So left side colon and rectum are coming under hindgut carcinoids. So the foregut carcinoids, and each carcinoid has special substances produced. Foregut carcinoid produces what substance? ACTH. So they produce what syndrome? Well known, Cushing syndrome. Therefore they produce Cushing syndrome. Midgut produces serotonin, histamine, bradykinin. All these substances are produced by midgut carcinoid, and this produces a syndrome known as what syndrome? Carcinoid syndrome. Please don't forget, that is known as carcinoid syndrome. We will be discussing about it soon. That is known as carcinoid syndrome. And this is an expected MCQ. Hindgut carcinoid produces what substances? Somatostatin. Somatostatin and peptide YY are the substances produced by hindgut carcinoids. So foregut carcinoid produces ACTH, midgut carcinoid produces serotonin, histamine, bradykinin, hindgut carcinoid produces somatostatin and peptide YY. Now tell me, what is the most common site of carcinoid tumor? Most common site of neuroendocrine tumor is, answer is, most common site of neuroendocrine tumor in this list is bronchus. No confusion in this. Followed by appendix. Appendix is the second common site. Followed by ileum. In the ileum, it is usually seen in the terminal ileum. So the order of carcinoid tumors is bronchus, followed by appendix, followed by ileum. No confusion, no controversy. Okay. If they ask you what is the most common site in GIT, now tell me what is GIT, gastrointestinal tract. Answer is, no doubt, it is appendix. Most common site in GIT is appendix. If they ask you what is the most common system affected by carcinoid tumor is GIT, more common than respiratory system. So in GIT we have around 70% of the carcinoid tumors, and in bronchus we have 20 to 30% of the carcinoid tumors. Though bronchus is the most common site, it is around 20 to 30%. Okay, so appendix, ileum, colon, stomach, everything together will come under 70%. There is no controversy in this. Please don't get confused in this concept. Most common site is bronchus. Most common site in GIT is appendix. Now let me tell you two fellows. This is Mr. Ramu and this is our friend Mr. Somu. So these two guys are going to develop now carcinoid tumor of ileum. They are going to develop carcinoid tumor of ileum. Let us assume carcinoid tumor they are developing in the ileum, both guys. So now let us assume this is Ramu's small intestine. He has developed a carcinoid tumor in the ileum with no mets, And this is Somu, who has carcinoid tumor in the ileum that has produced mets to the liver like this. So in other words, we can say Ramu is having primary carcinoids. Somu is having secondary carcinoids. Who will come to hospital now? Ramu will come to hospital, Somu will come to hospital. So if you see here, from Ramu, the carcinoid tumor produces serotonin, histamine, bradykinin, everything is produced. But all of them directly go to where? They all go to liver. And in the liver, they are detoxified into non-toxic products known as 5-hydroxy-indolacetic acid. They are detoxified to 5-hydroxy-indolacetic acid. So they are asymptomatic and usually they don't come to hospital. So primary carcinoid is asymptomatic, they don't come to hospital. If at all, the most common symptom from Sabiston is, what is the most common symptom from Sabiston? Pain abdomen. From Harrison, diarrhea. So Sabiston says pain abdomen, Harrison says diarrhea. Which you think should be taken for exam? If both are there in the choices, I would ask you to take Sabiston, not Harrison. It is Sabiston and the surgeons who deal with carcinoid tumor, not the physicians. Okay, so go with pain abdomen if both are there in the choice. Otherwise, the answer is pain abdomen and diarrhea. When you come to the secondary carcinoids, now if you see Somu, the hormones are now released from the liver itself. Now the hormones like serotonin, histamine, bradykinin, all those substances, tryptophan, everything is released from the liver. Now they are directly entering systemic circulation. And as they enter the systemic circulation, they produce a syndrome known as carcinoid syndrome. So the secondary carcinoid patients always comes to hospital with a syndrome known as carcinoid syndrome. Primary carcinoid patient like Ramu will not come to hospital. Secondary carcinoid tumors, the carcinoid syndrome, they come to hospital. They are characterized by 5 features. Carcinoid tumor syndrome is characterized by 5 features. What are they? The most common feature of carcinoid syndrome is cutaneous flushing. Most common is cutaneous flushing. The skin, there will be patchy flushing. So there are many types of flushing like bright red patchy skin flushing due to serotonin. Bright red patchy flushing, violaceous flushing, like that there are many types, and which can be asked in exam is this bright red patchy flushing is characteristic of gastric carcinoids. Please don't forget this. This is asked in PG and super specialty exams. So in case of gastric carcinoids, there is a special type of flushing known as patchy flushing here and there. So bright red patchy, violaceous, there are many types of flushing. You do not worry about those things, but remember the most common symptom is cutaneous flushing. Okay, the most common symptom is cutaneous flushing. Then bronchospasm. Then 5 features. Pellagra. Why there is pellagra? All of you know the 60 mg of tryptophan gives 1 mg of niacin from biochemistry. You all know from biochemistry, 60 mg of tryptophan gives 1 mg of niacin. Okay, 1 mg of niacin from 60 mg of tryptophan. So here the tryptophan is totally going into serotonin pathway and no niacin produced. So that is pellagra. That is the reason for pellagra in this carcinoid syndrome. And they have explosive diarrhea due to excessive fluid secretion, and there is explosive diarrhea. And last feature is very important for MCQ purpose. It is known as cardiac manifestations. So these are the 5 features. Cardiac manifestation is the last important feature you should remember. So in cardiac manifestation, which side heart is commonly affected? Left heart or right heart? Right heart failure is seen. Right heart is more commonly affected. And it affects the valves of right heart valves are commonly affected. So what is the most common valve affected in carcinoid syndrome? Most common valve affected is tricuspid valve. Sabiston gives the important point here. Most common lesion is what? Most common lesion is pulmonary stenosis followed by tricuspid regurgitation followed by tricuspid stenosis is the order. So what is the order of cardiac manifestation? Means pulmonary stenosis followed by tricuspid regurgitation followed by tricuspid stenosis is the order. Please don't forget this. And I would request you to remember pulmonary regurgitation not seen. Pulmonary regurgitation is not seen. So these are the 5 classical features of carcinoid syndrome. 5 features of carcinoid syndrome. So carcinoid syndrome is characterized by cutaneous flushing, most commonly bronchospasm, pellagra, explosive diarrhea, and cardiac manifestations. And most common lesion in cardiac manifestation is pulmonary stenosis, tricuspid regurgitation, tricuspid stenosis. These are the points you should not forget in carcinoid syndrome. Okay, carcinoid syndrome. Now let us go to the investigations. One of the important topics, carcinoid syndrome is one of the important topics you should not miss. Investigation of carcinoid syndrome includes number 1. Investigation of choice to diagnose is 24 hours urinary 5-hydroxy-indolacetic acid is the investigation of choice to diagnose. And what is the tumor marker for carcinoid tumor? Tumor marker. They have a tumor marker known as chromogranin A and synaptophysin. The tumor marker of carcinoid tumor is chromogranin A and synaptophysin are the 2 important tumor markers. Please don't forget the tumor markers. And now we have found out there is a tumor from the tumor marker and from the urine analysis. Now your aim is to localize the tumor. Your aim is to localize the tumor and your aim is to look for metastasis. So to localize the tumor, investigation of choice in those days is somatostatin receptor scintigraphy is investigation of choice in those days. Now this is being modified and a new investigation has come because all carcinoid tumor have a somatostatin receptor. That concept is used known as SRS, and we have a new concept now, DOTA-TET. DOTA-TET scan is the investigation of choice to localize the tumor. Where is it seen? Now the answer is DOTA-TET scan from the latest edition Sabiston. Okay, please don't forget the investigation to localize the tumor is DOTA-TET scan. To look for mets. So liver mets. To look for liver mets, investigation of choice is MRI. If they ask you what is the investigation of choice for liver mets, answer is MRI. If they ask you what is the investigation of choice for mets, last year AIMS question for super specialty. For mets, overall answer choice given was PET-CT, SRS, DOTA-TET, and MRI, whole body MRI, which is correct answer. Investigation of choice to look for mets in your body. What is the correct answer? If it is a cancer, carcinoma, Carcinoid tumor has low Ki67 index. Please remember this point. Ki67 index is a tumor growth index. So tumors which have high Ki67 index will be picked up by PET-CT. Those tumors with low Ki67 index, PET-CT not useful. Please remember interesting point. So carcinoid tumor, PET-CT is not useful at all. It is not useful at all. So therefore, for a carcinoid tumor, investigation of choice to look for METs is again the same DOTA PET-CT. High yield MCQ for example. If they ask you investigation of choice for carcinoid liver METs, you can go for MRI. But if they ask you investigation of choice for overall METs, it is DOTA TET, and PET-CT is not useful for carcinoid tumor, not useful for carcinoid tumors. Okay, please don't forget this points in investigation. And certain MCQ points or MCQ high yield points from carcinoid. Let me tell you now. From carcinoid, let me tell you some MCQ points. I told you intra-abdominally, if there is a carcinoid tumor, it will produce symptom only when there is metastasis to the liver like this. Only when there is metastasis to the liver, it will produce symptoms. Now tell me, what are the intra-abdominal carcinoids? What are the intra-abdominal carcinoids which will produce the syndrome known as carcinoid syndrome without liver mets? Which will produce carcinoid syndrome without producing a liver mets. Very interesting MCQ, no? It is taken from Sabiston. So without liver mets, carcinoid syndrome is seen in two conditions, expected MCQ. One is retroperitoneal carcinoids and another is ovarian carcinoids. So retroperitoneal and ovarian carcinoids, they directly drain into IVC. They don't go into the portal vein. Therefore, they produce carcinoid syndrome without liver mets. Without liver mets, they can produce carcinoid syndrome. This is one MCQ. And metastasis to liver. Metastasis to liver is a very important prognostic factor. It depends upon number one, what is the factors which decide the mets. Number one, size of the tumor. If the tumor is less than 1 centimeter, there is only less than 10% mets. If it is more than 1 centimeter, there is 90% chances of liver mets. So the factors depicting the mets are number one, size. Number two, site of the tumor. Which tumor produces more mets? So please remember, ileum produces highest liver mets, lowest with appendix. Appendix carcinoid produces lowest liver mets. So size, site, and third one, already I told you, Ki67 index. Based on Ki67 index and the grade of the tumor. Low Ki67 index, low grade tumors, less mets. High Ki67, high grade tumor, increased mets. So metastasis to liver depends on these points. Size of the tumor, site of the tumor, Ki67 index. Okay, please don't forget these points. And next I'm telling you some MCQs asked from this. Second most common tumor in carcinoid patients. That is an interesting point. Carcinoid tumors will have another tumor. Second most common tumor in carcinoid tumor is colorectal cancers. Please don't forget this. They may have colorectal cancer as the second most common tumor. And another interesting point is carcinoid tumors are many times they are multicentric, not always. They are many times multicentric nature. So even if you find out carcinoid tumor in one place, you should search for the multicentric nature. So it can be multicentric in nature. Carcinoid tumor can be multicentric in nature. Please don't forget this point also. So these are the MCQ points from carcinoid tumor. And coming to the conclusion on management of carcinoid tumors. So carcinoid tumors, treatment of choice is surgical resection. Don't forget this. Carcinoid tumors, treatment of choice is always surgical resection. Whenever possible, wherever possible, resect it. Even it may be R0, R1, or even R2. Don't worry, resect it. What is R0 resection? Complete removal. There is no microscopic residue. There is no microscopic residual tumor left. We have removed everything. In a cancer adenocarcinoma, we should aim for R0 resection. R1 is microscopic residual tumor is left. Microscopic residual tumor is left in the body itself. R2 is macroscopically left. We are knowing that there is going to be a huge amount of tumor after removing the tumor also. So macroscopically we know that there is going to be some tumor left. So whatever may be the resection, try the best with the carcinoid tumor. R0, R1, R2, anything you can do. We have to resect as much as possible. Even if there is liver mets, we can even resect the liver mets also. We should resect the liver mets also. So which tumor has good prognosis even with liver mets? This carcinoid tumor. Which tumor has good prognosis even in the presence of liver mets? His first answer is neuroendocrine tumor, that is carcinoid. And second answer is colorectal cancer with liver mets. That is why these two cases only liver mets we operate. There is guidelines advising you to operate neuroendocrine tumor with carcinoid and colorectal cancer with liver mets. We can operate. So the best prognosis is seen with carcinoid with liver secondaries. We can go and resect that secondary. Even if there is a microscopic residual, don't worry, we have to resect it. And if there is a carcinoid tumor in the small bowel, we should resect that tumor along with the mesentery with the white margin. So we have to resect the tumor with a margin of 10 centimeter, including the mesentery. We have to resect the carcinoid tumor. If it is small bowel or large bowel, wherever it is, the primary should be resected. The primary should be resected in carcinoid tumor. And especially if it is an appendix carcinoid. If it is in the tip of appendix, less than 1 centimeter, no infiltration into mesoappendix. Like this is a mesoappendix, no, this is mesoappendix. There is no infiltration to mesoappendix. The treatment of choice is what? Just appendicectomy is enough. Appendicectomy is enough. But if the tumor is in the base, or if it is in the tip more than 2 centimeters, or in the base, or if there is infiltration to the mesoappendix, in all these cases, we should plan for right hemicolectomy. So appendix carcinoids, when will you do appendicectomy? This is MCQ. When it is in the tip, less than 1 centimeter, no infiltration of mesoappendix, we can do appendicectomy. And if it is more than 2 centimeter involving base or mesoappendix, we have to do right hemicolectomy. Then what about 1 to 2 centimeters? 1 to 2 centimeter tumor. If it is a 1 to 2 centimeter tumor, also we can do appendicectomy if there is no mesoappendix infiltration. And in the tip, if there is a tumor 1 to 2 centimeter in the tip, like this, we can do appendicectomy if there is no mesoappendix infiltration. In the base, any size tumor, 1 centimeter, 2 centimeter, even half centimeter, we should do only right hemicolectomy. So please don't forget these surgical points in these carcinoid tumors. After surgery, if there is some residual tumor or residual, we have to give them chemo drug. Drug of choice. What is the drug of choice? So drug of choice for residual or microscopic or macroscopic remnant of carcinoid tumor is lanreotide, pesirotide, are all many new drugs are coming. These are all somatostatin analogs. Previously we were using octreotide. So octreotide is now replaced by lanreotide. It is a long-acting somatostatin analog. And new drugs are coming like pesirotide. And SWATS gives one new treatment for carcinoid tumor known as smart bomb. Smart bomb is a new type of treatment for carcinoid tumor, and there is a pilot study going on from 2000 to 2010. The study has been completed, and they have confirmed this smart bomb is excellent for carcinoid tumor, and those patients are on follow-up now. Soon they will be announcing the results. And what is it? If there is a tumor, let us assume this is a tumor. The tumor has, what is this? Tumor has somatostatin receptor. The concept of smart bomb is we carry the radiotherapy particles with the somatostatin. This is somatostatin attached. The radiotherapy particles are attached with somatostatin and injected into the patient. As it is injected, these particles, this radiotherapy carrying particles, will go and sit in the exact somatostatin receptor like this, and it will burst the tumor. It will burst the tumor directly. Smart way, it will act only on the tumor. This is known as smart bomb. It is a future of carcinoid tumor. So in future, the carcinoid tumor may be treated by smart bomb. Maybe after 10 years, you will be taking a class. The treatment of choice for carcinoid is smart bomb. Okay, that is the upcoming future. So these are the points in carcinoid tumor. Let me show you the images from carcinoid tumors. So carcinoid tumor is a very important topic. Please don't forget. So overall, the most common tumor of small bowel is GIT primary producing mets. So this table is there in your book. So please follow this table. And most common extra GI primary is melanoma. Please don't forget this point also. So most common benign tumor is adenoma. Most common malignant tumor is adenocarcinoma in small bowel. So the controversies I have cleared very well. The most common site of carcinoid in GIT is appendix. Overall common site is bronchus. Which system is common is GIT? Which system is common is GIT? So please don't forget various points I told you. Bronchus carcinoids are foregut carcinoids. Midgut carcinoids produces serotonin. Hindgut carcinoid produces somatostatin and peptide YY. All these points we discussed. Carcinoid syndrome, in cardiovascular manifestation, carcinoid syndrome, which is most common, pulmonary stenosis is most common, 90%. So tricuspid regurgitation is only 47%, and tricuspid stenosis is 42%. So please don't forget carcinoid syndrome. So various types of flushing I told you, erythematous, violaceous, prolonged, bright red patchy. Bright red patchy is seen in gastric carcinoids. Okay, please don't forget that point. So the neuroendocrine tumor marker is chromogranin A. And please don't forget the investigation of choice to diagnosis 24 hours urinary 5-HIAA, 5-hydroxy-indoleacetic acid. And multicentricity is common in carcinoid tumor. Second common tumor is adenocarcinoma of the large intestine. Carcinoid tumor may be associated with MEN1. All these are some MCQ points. And Sadistan says MRI is useful for detecting liver mets, and DOTA test is the investigation of choice, 97% sensitive for other mets. So please don't forget about the smart bombs. Smart bombs you should not forget. So they are nothing but radio-labeled somatostatin analogs. They deliver radiotherapy directly to the carcinoid cells. So this is a tumor. For this tumor we should give 10 cm clearance. So for adenocarcinoma we have to give 10 cm clearance. And CT enteroclysis can be advised. CT enteroclysis is the investigation. Its accuracy is about 90%. So it's a CT scan only. In a CT scan we will give oral contrast and take a CT scan. Okay, that is known as CT enteroclysis. So please don't forget these points. This is small bowel adenocarcinoma. We should give 10 cm clearance and clear the small bowel adenocarcinoma. Okay, thank you.